Hello, everyone. I hope everyone can hear me. My name is Dr. Andy Blauvelt. Welcome to the 2023 Global Webinar Series, #1 for the International Psoriasis Council. I'm happy today to have with me several experts in this area who I'll introduce in a few moments. All of these investigators have been working in the area of psoriasis and heart disease. So the title of the program is Current Knowledge and Future Directions, Psoriasis and Heart Disease. A few housekeeping measures. The webinar will last 60 minutes approximately, and the webinar is being recorded. Your audio should be muted, and please ask questions through the Q&A part of the Zoom program. So not the chat function, but the Q&A, and I'll be monitoring that, and we'll go over the questions at the end. So we hope for your participation, and you can enter those as the talks are going on, but we'll kind of collect them at the end and go over everything that you may be thinking about near the end of the webinar after the presentations. The recording will be available at psoriasiscouncil.org for your viewing, or if your colleagues wish to view the program in the future. Again, my name is Andy Blauvelt. I'm from Portland, Oregon. I'm a member of the International Psoriasis Council and a board member as well. So what is the IPC? The IPC was founded in 2004. It's a dermatologist-led, voluntary, global nonprofit organization with a network of 133 psoriasis experts, thought leaders, and professionals dedicated to improving patient care around the globe. The vision for the IPC is a world free of psoriasis, and our mission is to improve the care of people with psoriasis worldwide through research, education, and advocacy. We believe that people with psoriasis, no matter where they live in the world, no matter how complex their symptoms, should have access to the best care available to them, and that ultimately a world without psoriasis is possible. Our key areas of focus are access to care around the world, research of a variety of different types, medical education, as we're doing today, and regional development of psoriasis care around the globe. Now, going to today's program, we have 3 excellent speakers. I'm excited to hear from them. We will first hear from Dr. Michael Garshik, who is at NYU, New York University, and he is actually a cardiologist joining us dermatologists today. So we really appreciate Michael's involvement in giving his perspective as a cardiologist on psoriasis and heart disease. We'll next hear from Dr. Joel Gelfand, who many of you know is at the University of Pennsylvania. Joel's been pivotal in many research studies, as we will hear, in this area of psoriasis and heart disease. And lastly, we'll hear from Mona Stahl, who is at the Karolinska Institute in Stockholm, Sweden, our European contingent today. And Mona will go over real-world evidence that we've seen in large databases on psoriasis and heart disease. Just a little bit, this is the first of several webinars that the IPC is sponsoring this year. We'll have additional ones in the near future on psoriasis and cancer, psoriasis in the joints, and psoriasis in the gut. So the focus this year for these IPC webinars is comorbidities and psoriasis. So with that, I am going to now introduce Dr. Michael Garshik. So Michael is a cardiologist and assistant professor at New York University in New York City, and with appointments in both medicine and dermatology. His research interests are in exploring the mechanisms behind the heightened risk of cardiovascular disease in patients with immune-mediated inflammatory diseases, specifically focusing on platelet activation and endothelial cell damage in these patients, and especially in psoriasis patients. He conducts clinical trials and is director of the cardio rheumatology program at NYU, dedicated to reducing cardiovascular risk factors in patients with heightened systemic inflammation. And so with that, I am going to have Dr. Michael Garshik share his screen and get us started. So thank you.
Thank you. Good morning. It's really a pleasure and an honor to be here today. I very much appreciate the kind introduction and the invitation to speak. And today I'll be speaking about exploring the pathophysiologic links between psoriasis and heart disease. These are my disclosures related to the talk today. Okay, so I wanted to start the day with a clinical case to try to provide some clinical translational interests in this topic. And this is someone who I think many of us may see in our practices, whether it's cardiology, rheumatology, or dermatology, or primary care. This is a 50-year-old male who feels well. He's mildly overweight. He does exercise. He's got mild hypertension, yet he's a non-diabetic, a non-smoker. He's got this metabolic lipid profile with a slight reduction in his HDL and mild elevation in his triglycerides. Yet despite that, he is not a diabetic nor a pre-diabetic, and his CRP is 1.5. So for this patient, his only real medical problem for him is plaque psoriasis. He's had it since the age of 35. While it was fairly extensive, involving over 10% of his body surface area, it cleared after starting targeted biologic therapy with an IL-17A inhibitor. And so this patient comes with a few questions today. This is going to frame the outline of the talk. Is he at risk of a clinical cardiovascular event, and how does psoriasis impact that risk? Why is he at elevated risk if he is? And what can he do to lower his risk? So right off the bat, we know this patient has an elevation in his traditional cardiometabolic risk factors. And as we know, this is very common in psoriasis. This is a summary slide detailing those associations, where psoriasis patients have anywhere between a 1.5 to 3-fold or higher odds of the traditional cardiometabolic risk factors when compared to non-psoriasis individuals, such as hypertension, obesity, diabetes, or metabolic syndrome, dyslipidemia, and smoking. Now, even after you adjust for those traditional cardiometabolic risk factors, psoriasis still associates with cardiovascular events. This is Joel Gelfand's original study, which most of us still quote today, where using a large UK prospective database, he showed that overall, patients with psoriasis have an approximately 50% increased risk of an MI when compared to controls. Now, there's also this dose-response relationship, whereby those young patients with severe psoriasis seem to have the highest relative risk of a cardiovascular event. So why do we think this relationship occurs? Well, psoriasis is very pro-inflammatory, and systemic inflammation is linked with the development of atherosclerosis. So to back up, how do you get psoriasis? Well, you generally have this genetic predisposition. It's combined with environmental stimuli, and that generates a cascade of cytokines linked to dendritic cell activation. You get further cytokine production, such as TNF, IL-23, which drives T cell differentiation at Th17 cells, and you get this feedback loop that develops, which eventually ends up in resulting keratinocyte hyperproliferation, which also generates more cytokines. And you'll notice here that many of these cytokines, which are being produced, such as TNF, IL-6, the IL-1 beta and alpha, the S100s, they're not just pathogenic in psoriasis, but they're also felt to be causal in atherosclerosis. So then how does psoriasis directly relate to atherosclerosis? Well, a key step in the development of atherosclerosis is vascular endothelial damage. Endothelial cells are cells that line and protect the blood vessels, and they participate in many physiologic functions. So today, I wanted to present some of the data we've generated in collaboration with dermatologists across the US to understand if endothelial damage is present in psoriasis, and if so, why, as a key first step in the initiation of atherosclerosis. So one way to explore this question is actually to start at the site of primary involvement, which is the skin. So these are skin biopsies. This is healthy control skin. The top is immunohistochemistry, the bottom is immunofluorescence. The green is the blood vessel, the red is inflammation. There's very little inflammation present in this blood vessel. This is non-lesional skin. So you have a plaque on your abdomen, we biopsy your arm. First of all, the blood vessel is a little bigger. Now there's also more red, more inflammation surrounding that blood vessel, and actually inside that blood vessel as well, some yellow or cold localization. And now, for comparison, this is lesional psoriatic skin biopsy. They're dense inflammatory infiltrates, a dilated and plump blood vessel, and vascular inflammation is present here as well, really highlighting how psoriasis is really a systemic process. But of course, as we know, the majority of cardiovascular events happen in the macrovasculature, not necessarily in the microvasculature. So one way you can explore the macrovasculature directly is to look at the vascular endothelial cells with a technique called vascular endothelial cell biopsy. To do this, you find the brachial vein, you put an angiocatheter into the vein. You then take a small wire, thread it through the angiocatheter, and gently scrape out, isolate, and analyze endothelial cells. When we do this and look at the inflammation, we see that endothelial cells from psoriasis platelets are actually very much damaged. The top is control, the bottom is a psoriasis patient. The green is the endothelial cells, the red is the inflammation. The more red going into the blue, the more inflammation is present. And you can see here both in the pictures and in the quantification that vascular endothelial damage is present in psoriasis patients. But extending beyond this non-specific inflammation, what are the actual mechanisms responsible for atherosclerosis? What are the endothelial cells producing or doing? These are a variety of genes we've looked at being produced from those endothelial cells, all causal in atherosclerosis. And when you look at controls compared to moderate and moderate to severe psoriasis, the majority of these genes are differentially expressed in psoriasis endothelial cells, and a dose-response relationship exists, whereby the greater the psoriasis, the greater the expression of these transcripts. So thus far, we've identified that yes, the vascular endothelium is inflamed and damaged in psoriasis patients, and we want to understand why. So one really understudied cell are platelets. Platelets traditionally think are involved in hemostasis and thrombosis, but they're also implicated in atherosclerosis and atherothrombosis, the active MI process. We wanted to see if they had a role in psoriasis pathology. So to our surprise, platelets were actually present in psoriatic skin. This is a normal skin biopsy. There are no platelets present. Now this is immunohistochemistry and immunofluorescence. You can actually see platelets clumping in the lesion of psoriatic skin, and the green highlights this process by immunofluorescent studies, that platelets are present in skin of psoriasis lesions. Not only are these platelets present, they're also highly activated. Psoriasis platelets have higher platelet p-selectin expression. You can actually see a relationship between platelet p-selectin expression and IL-17A production. These platelets also clump or aggregate more with neutrophils and lymphocytes. These processes are all felt to be biomarkers and causal in atherogenesis. These psoriasis platelets are not just activated, they also clump or aggregate more as well. When you take psoriasis platelets and random controls and look at how quickly they aggregate to a variety of agonists, the platelets are not just activated, but also hyperaggregators in psoriasis platelets. We also want to understand the implications of these findings in platelet activation and aggregation. So we took psoriasis platelets and we put them on cultured endothelial cells. And if you go all the way to screen right, you'll see, first of all, these platelets from psoriasis platelets patients, they adhere to the endothelial cells. They're also highly activated. They're actually cellular processes sticking out of these platelets. But then not just are they adhere and activated, they're also activated in the endothelial cells. You can actually see cellular processes sticking out of these endothelial cells as well. What are these psoriasis platelets doing to the endothelial cells? Well, these endothelial cells, after psoriasis platelet co-incubation, get highly angry and damaged. So they produce more IL-8, IL-1 beta, and COX-2 when compared to having platelets from healthy controls put on them. So when we start thinking about the factors that influence cardiovascular disease and psoriasis, it's clearly the combination of clinical variables. There's also pathophysiologic variables such as platelets. And there's also immune cell dysregulation. So as we've highlighted many times, psoriasis is a systemic inflammatory process. And one way you can try to explore this more deeply and how it relates to cardiovascular disease is by looking at the immune signature in psoriasis and how it associates with enhanced cardiovascular risk. For example, we performed whole blood RNA sequencing. So we looked at the gene signatures that are circulating in the psoriasis patients. They predominantly come from white blood cells. And we noted that almost 400 genes were higher in psoriasis whole blood than in controls. There is also a relationship of about 1,200 genes that relate directly to psoriasis skin severity. And when you look at the overlap between the two groups, about 73 genes were significant in the psoriasis patients than in the controls. These 73 genes or transcripts circulating in the blood were produced from predominantly white blood cells. And they're regulated by many of the cytokines that have been shown over and over again to be upregulated in psoriasis, such as interferons, IL-4, TNF, inflammasome-mediated ones such as OSM and IL-1 beta. But that's not all. Out of these 73 genes, 29 genes were present in patients who were having an active heart attack. So what I mean is the same process happening in patients with active psoriasis is actually happening in patients who are having an active MI. Now, out of these 29 genes in the patients that were having an active MI, they also predict and associate with future cardiovascular events. See, these are some of the biggest candidates here that we kind of pulled out from this process, trying to figure out what is a unique cardiovascular signature in psoriasis that not just associates with the cardiovascular events, but could also have these mechanistic implications. So, of course, given the high cardiovascular immune signature in psoriasis and the circulating blood, one would expect that treating psoriasis reduces cardiovascular events. I'll let Drs. Gelfand and Stahl answer this, what I think, fairly complicated question in later slides. But as a preventive cardiologist, we wanted to focus on some different prevention strategies. So we had pretty good data that platelets were activated in psoriasis patients. And as we know, aspirin inhibits platelet activation and aggregation. It also is a commonly used prevention medication. So we wanted to explore if aspirin could be beneficial in psoriasis. We took psoriasis patients, we randomized them to aspirin, low dose, or no treatment, and we looked at their vascular endothelial transcriptome before and after these therapies. Now, these are relatively young psoriasis individuals, overweight to obese, fairly controlled blood pressure, low cardiovascular risk, but all with very real psoriasis disease, on average between 13 and 20 years of psoriasis duration, and on average moderate severity at the time of enrollment. In those patients who were randomized to 81 milligrams of aspirin, they actually saw a reduction in their vascular endothelial inflammation transcript expression, so actually improvement in vascular endothelial cell health when compared to the no treatment group. Now, we also measured thromboxane B2. So thromboxane B2 is a downstream metabolite from thromboxane A2. The greater the reductions in thromboxane B2, the more efficacious aspirin is. We actually saw a direct relationship between reductions in thromboxane B2 and improvement in vascular endothelial inflammation, suggesting a connection between aspirin efficacy and vascular endothelial health. So, as a preventive cardiologist, I'm also deeply interested in statins. So we did a similar clinical trial in statins in psoriasis. We took patients with psoriasis and we randomized them to 40 milligrams of atorvastatin or no treatment for 2 weeks. And we looked at the vascular endothelial transcriptome before and after. Similar to our aspirin clinical study, we saw a similar benefit with atorvastatin or Lipitor. You can see that after 2 weeks of 40 milligrams of atorvastatin, a significant reduction in the composite vascular endothelial transcriptome. When we started to look at the relationships, we noticed that the greater the reduction in LDL, so the greater the impact the statin had on LDL lowering, the greater the improvement in vascular endothelial health. This was actually in direct comparison to changes in CRP, where we really saw, even though we think that statins are anti-inflammatory and they have these pleiotropic properties, we did not see much of a relationship between degree of CRP reduction and improvement in vascular endothelial inflammation. So trying to come full circle, coming back to our patient, how do we approach him? I think, yes, he is at elevated cardiovascular risk. I think this is a combination of traditional risk factors plus the independent contribution from immune cell activation. So you should aggressively manage his cardiovascular risk factors, which is blood pressure control, lipid control. We will talk about psoriatic disease treatment later. I think the aspirin data is very exciting and interesting, but maybe not ready for prime time just yet. So thank you very much. There are a lot of people involved in these collaborative research projects, so I just like to point out some of them here and my sources of support.
Right, Michael, thank you very much. That was fascinating. I loved it. I have some questions myself, but we're going to get to those at the end. And so we got the next, you guys are way ahead of me. Dr. Joel Gelfand is already sharing his screen there. I just want to introduce Joel. So Joel, many of you know, is the James J. Leiden Professor of Dermatology and Epidemiology with tenure at University of Pennsylvania's Perelman School of Medicine. He is also Vice Chair of Clinical Research, Medical Director of the Dermatology Clinical Studies Unit, and Director of the Psoriasis and Phototherapy Treatment Center. The overarching goal of Joel's research and clinical practice is to improve psoriasis patient outcomes in the skin and joints while lowering the risk of diabetes, cardiovascular disease, and mortality. So we have my timer, sorry about that. He's, as you know, and as we're hearing, he's internationally known and recognized expert in psoriasis, clinical epidemiology, and in particular, this topic of heart disease. So he's going to go over the area of clinical trials to assess whether our treatments are affecting heart disease. Joel.
Yes, thank you, Andy, and hopefully people can hear me okay and can see my slides okay. The title of my talk is Exploring Whether Systemic Therapy for Psoriasis Improves Heart Disease in Clinical Trials. These are my disclosures. And I'm going to give three major elements of this talk, just to show a little bit of the evidence linking psoriasis to cardiovascular events, so we know the clinical significance, look at different clinical trial approaches used to date to look at how immune-targeted therapies impact cardiovascular disease, and discuss where I think our future opportunities are. So just briefly, this is a multifactorial problem that we are dealing with our patients. Patients have environmental risk factors that make them prone to psoriasis, genetic risk factors, the disease itself, as Michael sort of laid out, the therapies we use, and then the psychosocial burden. All of these things confer some degree of cardiovascular risk. I'll just point out one recent study that came out in Nature Communications using something called Mendelian randomization design. It's essentially a genetic study where they found the genetics of coronary artery disease were causally related to developing psoriasis over time. And so that just reminds us that these relationships may go back and forth. Psoriasis possibly could cause atherosclerotic disease and cardiovascular events, but also people have underlying cardiovascular disease or atherosclerotic disease that may also be a trigger for psoriasis as well, given that that's an inflammatory condition of itself. Now, there's real clinical significance to this problem. People with moderate severe psoriasis die about 5 years younger than they should, based on their risk factors for mortality. The 10-year risk of having a cardiovascular event attributable to psoriasis is about 6%. That's very similar to, say, diabetes. And a person who has moderate severe psoriasis is about 30 times more likely to experience a major cardiovascular event related to psoriasis than they are to develop a melanoma. And as dermatologists, we all do full skin checks on our patients. We know how important melanoma is, and this sort of puts it in context here. So if we're able to solve the cardiovascular risk problem in our people with psoriasis, we will do a major benefit for them, just the way we do when we screen for melanomas. Guidelines have come out to really emphasize these points. This is from the American College of Cardiology, American Heart Association, and psoriasis is now viewed as a cardiovascular risk enhancer, along with diseases like rheumatoid arthritis or HIV. And as I think Michael's talk showed earlier, many of the other comorbidities our patients have, including metabolic syndrome, or inflammatory arthritis, psoriatic arthritis, are also very prevalent in our patients. So our patients can have multiple cardiovascular risk enhancers. And according to these guidelines, they should be considered for statins earlier along their journey in cardiovascular risk management. And then finally, another paper just came out just emphasizing the breadth of data, a meta-analysis, 31 studies, 665,000 patients with psoriasis, 17 million controls. I can't think of any other disease out there that's been this intensively studied for psoriasis and cardiovascular risk. Even RA doesn't have this much data behind it at this point. All right, but this is really the key question. In 2006, when I was sort of involved in this area, all people told me, like, why study psoriasis? It's just a skin disease, doesn't harm anyone, it's just cosmetic. In Oregon, the insurance called Medicaid refused to treat psoriasis. I think it was elective to treat. It didn't require government funding to treat it. Incredible how far we've come based on the observational data, the genetic data, and the data that Mike just showed you in terms of our understanding of these relationships. But the problem is that the immune system can cause paradoxical effects. TNF inhibitors can be very anti-inflammatory, in the skin, the joints, but they can be pro-inflammatory in the central nervous system, and they can even cause psoriasis-like lesions. IL-17 inhibitors are very anti-inflammatory in the skin and joints as well, possibly also for hidradenitis, but can be pro-inflammatory in the gut. And then tofacitinib, well, we know it lowers hsCRP, but it seems to have issues with thrombosis and cause mortality. And again, just to emphasize this point, a lot of the basic work being done to look at IL-17 in cardiovascular disease, IL-17 seems to have both pro and anti-atherogenic effects in the various models that are looked at. So, there's basically two broad approaches to trying to tackle this question about what do our therapies do to cardiovascular disease. One is to do biomarker studies, and the second approach is to do event-driven studies. And these studies can either be observational in nature or randomized controlled trials in nature. And I would argue that the best data ultimately comes from randomized placebo-controlled trials or active comparator trials of events, because patients care most about events when it comes down to, as opposed to biomarkers. So, for the last sort of 10 years or so, Nehal Mehta and I have been working on this sort of model of 18-FG PET-CT as a measure of systemic inflammation and vascular inflammation in people with psoriatic disease. And the reason why we thought this was a very good model to study is because it's felt that radiolabeled glucose uptake is a marker of CD68 positive macrophages and fatty plaques, which is a driver of atherosclerosis. These imaging techniques are predictive of future cardiovascular events. And we've shown that vascular inflammation is increased in people with psoriasis compared to people without psoriasis, and that the worse their skin disease is, the worse their aortic vascular inflammation is. And then finally, other trials have shown that if people go on statins, medications known to prevent cardiovascular disease, that their aortic vascular inflammation will reduce within 4 to 12 weeks. So this is a nice imaging biomarker because it's highly sensitive and it changes rapidly, within a couple of weeks period of time. So that's very advantageous. And psoriasis is a particularly interesting model because we could give people placebo for a short period of time, 12, 16 weeks, whereas you cannot give placebo. And there's my dog who's agreeing with the talk right now. So we could give placebo. Let me pause for 1 second. I'm very sorry. I'll let the dog out. Give me 1 second. Out you go, boy. Out you go.
I think he's interested in the topic, Joel.
I know. Well, he clearly disagrees with some of my hypotheses. I apologize for that. Okay, so basically, it's a useful marker because it responds quickly. And with psoriasis, we can give people placebo. You can't really give people placebo, say, with rheumatoid arthritis or other inflammatory diseases. So it's a nice experimental model. And we've conducted 4 of these trials. 3 were randomized placebo-controlled. 1 was adalimumab versus phototherapy versus placebo. That was sponsored by the NIH. 1 was an IL-17 inhibitor, secukinumab versus placebo. That was sponsored by Novartis. And then 1 was ustekinumab versus placebo. That was sponsored by Janssen. All of these are investigator-initiated studies, all studies that we did and analyzed and reported. And finally, most recently, report on the VIPA study. It's an open-label study of apremilast. And this is sort of a summary of our work and other work in the literature, looking at randomized placebo-controlled studies of cardiovascular biomarkers in people with psoriatic disease. And so there's been 2 studies of adalimumab, one by Robert Bissonnette in Canada, and one by us. And then also our study of ustekinumab, secukinumab, and another one of secukinumab that was looking at flow-mediated dilation. And the summary of what we found in this meta-analysis, was published in the JID about a year ago, is that the strongest reduction in blood-based cardiometabolic biomarker risk factors was observed with adalimumab, which improved CRP, TNF, and IL-6A, and a biomarker called glyc-A. IL-6 is interesting because it's causally related to cardiovascular disease. We know that from a variety of lines of work. So when you lower IL-6, it gives you a lot of confidence that you're likely to lower cardiovascular events. Interestingly, phototherapy lowered CRP and also lowered IL-6 as well. And only phototherapy in this model improved lipids and increased HDL particle size. Ustekinumab, which blocks IL-12 and 23, improved aortic vascular inflammation at week 12, but that was transient. When we followed people out for a full year, it went back to their baseline. And then none of the therapies we use seem to improve insulin resistance. And so that gives you some insight to where things are with these biomarker-based studies. All right, so briefly about apremilast, this also had a neutral impact on aortic vascular inflammation. Although interestingly, people who had higher levels of aortic vascular inflammation at baseline had improvements in their VI at week 16. But what's most interesting about this study is that subcutaneous and visceral fat reduced by 5 to 6% in apremilast patients, and that was maintained for 52 weeks. That's kind of an interesting observation from this study. And we know metabolic problems are such an issue in patients with psoriatic disease. There are also a number of improvements in a variety of different metabolic biomarkers as well. But again, this is not placebo-controlled. And part of the reason why I argue that placebo control is so important is you can see this work that Nehal had led, I was a collaborator on, showing that anti-TNF therapy in people with psoriasis is strongly associated with a reduction in the aortic vascular inflammation. So that's observational data, borderline p-value, but still significant. But when we did it in clinical trials, at least 2 trials, proving no benefit of adalimumab on aortic vascular inflammation. So placebo control is often very important in these highly sensitive markers. A place where the work may go next is Nehal's been developing the technique of coronary computer tomography angiography for studying plaque disease, in this case, atherosclerotic plaque. And what he's able to show is that psoriasis is associated with an increase in non-calcified plaque burden and high-risk features that seems to improve with a year of biologic therapy. And again, that's work that we want to now look at with RCTs. The other issue about biomarker studies is that they're often not accurate in terms of predicting the true outcome of events. This is a review in the cardiovascular literature, roughly a 55% positive predictive value of when you do a clinical trial of a biomarker and then following it up with the RCT of actual events. Do you actually find confirmation of improvement in events? So you always have to do the event-driven study after the biomarker study. So there have been 3 major clinical trials now looking at immune-targeted therapies and cardiovascular events in the cardiovascular field. So here the model is looking at people with very high cardiovascular risk because they have established cardiovascular disease, have had a prior MI. The canakinumab study, it's a biologic blocking interleukin-1 beta, and that did reduce cardiovascular events in these patients, but had an increased risk of infection and mortality due to infection. And so that made it not a very viable strategy for secondary prevention. But you also notice the sample size, 10,000 patients, average age 61. Methotrexate, there's a study based on observational data and biomarker data, which thought it would be effective in lowering cardiovascular risk. This had no benefit whatsoever in cardiovascular risk in people who had a prior MI or multivessel coronary disease and diabetes. Interestingly, there was a small increased risk of non-BCC skin cancer and an increased risk of non-serious infections, but the drug was actually pretty safe in a large population of people, nearly 5,000 people, who were about 66 with coronary disease and diabetes. So that's reassuring for our use of it. And finally, Colcott, colchicine. There's a study of people who had a recent MI, and here they had a reduction in having another MI in the future if they got colchicine compared to placebo. There was an increased risk of pneumonia as a serious adverse event. And the colchicine findings have been replicated in other clinical trials. So some preventative cardiologists are now starting to use it in patients. More recently now, coming back into our field of inflammatory diseases, there was the oral surveillance study published in the New England Journal of Medicine. This was a randomized open-labeled study of TNF inhibitors versus tofacitinib in people with rheumatoid arthritis. They had to be 50 or older and have at least one cardiovascular risk factor. And what this study essentially showed or conclude is that TNF inhibitors, or I should say tofacitinib, is not non-inferior to TNF inhibitors when it comes to cardiovascular events. Stated another way, you seem to get better cardiovascular event outcome rates if you get a TNF compared to getting a JAK inhibitor. And so that raises the issue for us to keep in mind that we have all these different targets in psoriasis to use, and which target we use may have different impacts on cardiovascular events. We still need to tease that out. So in my last minute or so, I'll just say that I think we have three approaches going forward. One would be imaging coronary arteries, like I showed you earlier in the talk, the coronary angiography. The advantage here, that's the money. That's where we're trying to go to improve athero and cardiovascular and the coronary arteries themselves. The disadvantage is that it takes about 12 months to see changes here. You need sample sizes in the hundreds of people, and you probably need an active comparator. We can't give placebo to people with psoriasis for a year. Maybe doing these studies in people with cardiovascular events or people who have known coronary disease. This is relatively efficient because they have very high risk. So just like we studied methotrexate in people with coronary disease, we could study, an IL-17 inhibitor or an IL-23 inhibitor or a TNF inhibitor in that population. The challenge with these event-driven studies, it takes a good, year to 5 years to accrue enough events. You need sample sizes in the thousands, and we won't be certain that this plays a role in psoriasis because it's not going to be psoriasis patients. And then finally, studying for cardiovascular events in people with psoriasis. This would be really good for giving us insight to the natural history of disease. Following people in a randomized trial for years would be the definitive answer and could be pragmatic. But similar to the last design, you're talking about thousands of patients, many years of follow-up, a lot of resources to do this kind of study. So I'll stop there and thank my lab and funding sources that have helped me do all this research over the years, and delighted to stop there and hear the next series of talks.
All right, thank you, Joel. That was great, and thank you for your work for all of these years and pushing this area forward. The fruits of your labor are clearly seen here in this type of webinar and the type of research being done. So lastly, we're going to switch to Europe. We're going to switch to Stockholm. Dr. Mona Stahl is professor of dermatology and venereology in the Department of Medicine at Karolinska Institute in Stockholm, Sweden. She did her postdoctoral fellowship at Washington University in St. Louis, and she studied molecular biology focusing on matrix metalloproteinases in the skin. She returned to the Karolinska and continued to expand on this research in her laboratory. And for the past 20 years, her research is focused on the immunogenetics and epidemiology of psoriasis, building a research platform for translational studies at Karolinska. The patient cohorts are well established in Sweden, and they're followed in registries, and there's biobank material as well that supports her research. So with that, I want to thank Mona for joining us, and she's going to be discussing sort of real world evidence on this topic. Can psoriasis therapies affect heart disease? Mona.
Thank you very much for inviting me to this interesting webinar. I already learned a lot, actually. And my task, as you said, is to discuss today if we need real world data to support the concept. And actually, why do we need real world data when we have all this evidence from randomized clinical trials? I guess that the real world data usually serve to generate hypotheses for future randomized clinical trials, as the association between cardiovascular disease and psoriasis was found through real world data. But also subsequent to the randomized clinical trials, we usually need to generalize the results from the randomized clinical trials to include not such usually biased groups of cohorts that are tested in the clinical trials, and maybe also extend to new endpoints. So how do randomized clinical trials and real-world evidence data differ? I mean, like Joel said, the randomized clinical trials are superior because they include randomized patients and the study design is stringent and you can really draw conclusions from them. But usually selected patients, and they cost a lot of money. If you want to do long-term clinical randomized trials cost a lot of money, and the external validity may not be so high. The real-world data, of course, has better external validity, and you can generalize better with a better mix of included patients and have large patient materials. But of course, the lack of randomization is a real drawback, and the risk of inadequate study design is also a concern. And usually, if you want to do large trials, you have to combine multiple, maybe non-compatible data from different sources. But as I said, real-world evidence has really generated the hypotheses that have been studied and verified the disease, the connection between cardiovascular disease and psoriasis. The seminal paper from Joel, of course, we all read that in JAMA, and also meta-analysis. This is an early one from April Armstrong's group, but there are also later ones that go through the real-world evidence data. The mechanisms between cardiovascular disease and psoriasis are still not completely clear, even though today I learned some new things about thrombocytes from Michael here, very interesting, but I think it's a mix of different factors, including both lifestyle factors and cardiometabolic factors, and also all the immunology. And I guess that to design the clinical the real-world evidence studies, a better insight into the mechanisms is very important. So the question is that, can effective anti-inflammatory psoriasis treatment reduce cardiovascular risk? From the randomized clinical trials, it seems so. I'll share with you some data on real-world evidence and start with a Danish nationwide administrative data. You know that the Scandinavian countries, they have a real wonderful tool when it comes to epidemiology. We have the personal identification number. Each individual is assigned a unique code that you can trace individuals through huge administrative databases. And you can concentrate on the healthcare. You can get data on medications and comorbidities, causes of death, etc. So that is a unique opportunity that this Danish group, Alehoff and colleague, really exploited in two early studies, actually, one in 2013 and one a couple of years later, when they did a follow-up of the same databases, actually. In the first study, they compared biological agents with methotrexate, and they could see that there was a protective effect from treating patients with biological agents, methotrexate, compared to traditional systemics. The other study expanded on this. It was longer, 5 years, and they compared with cyclosporin, retinoids, and also UV light and phototherapy that was actually used a lot in those early days. These are early studies, and the number of patients are not so many, but a few hundreds at least. And here we could see that methotrexate and the biological drugs were rather equal, even though methotrexate in this study was superior to the biologics. The authors did an interesting sub-analysis comparing anti-TNFs with interleukin 12-23, ustekinumab. And they had not so many patients on ustekinumab, but you could see that the protective effect attributed to the biologics came from the anti-TNF treatment and not from the ustekinumab treatment. This is sort of, there has been a spotlight on interleukin 12-23 when it comes to cardiovascular risk. And as Joe alluded to before, we need to study all these drugs, I mean, all the biologics now and all the small molecules that are coming in different with different targeted effects separately. The strength is the long follow-up and the nationwide coverage, but these were early days for biologics, not so many patients. And there was also a selection bias when it came to recruiting patients. They were younger, there were more men in the biologic session, and they had limited data on potential confounders, even though they could retrieve a lot of data on comorbidities so that they could adjust their data to reduce some of the bias. The next study is a large study from the British register. They have a national register that collects all patients on biologics, the BADBIR. And the aim was to study the different biologics and in terms of safety for cardiovascular events. And they had quite a few patients, more than 5,000 patients. And the majority of those were anti-TNFs. And in the main study, they compared anti-TNFs against ustekinumab. And then they did a sensitivity study comparing all the different biologics to methotrexate. And they were able, because this biologic register contains a lot of clinical data, so they were able to create a surrogate for randomization, a propensity score, so trying to make the different cohorts as equal as possible when it comes to comorbidity and other factors that would influence the selection of treatment. So we can see here we have clinical scores for disease severity, we have PASI scores, we have all the comorbidities, we had diabetes, and we had smoking and alcohol. So they had quite good ability to compensate for and to adjust for the difference in the different cohorts. And here we can see the data comparing IL-1223 versus anti-TNF, and the blue dots are before adjustment. And here we could see that IL-1223 would seem to have a higher risk for cardiovascular events. But if you do the adjustment for these factors that actually influence the selection of treatment, you can see that this difference disappears. It seemed like a patient who had diabetes, who were obese, they were more selected to receive anti-IL-1223. So that's why they ended up with a higher cardiovascular risk. So it's very important with the adjustments, and that is a real challenge when it comes to real world data. And now I'm moving to another strategy that has been used in particularly in countries where we don't have access to these big databases. And these are studies on health claims data. And I will talk about two studies. They come from J.J. Wu's group. And in the first study, he compared the anti-TNFs with methotrexate. Already here we can see that there is a bias in the selection of treatment in the anti-TNF group. There were younger patients and more men. And of course, there is a complete lack of clinical assessments. Even if you get a lot of data on comorbidities and medications, because this is something that you can tease out of the health claims databases as well. And here we can see that there is difference, especially if you in the I can't see my slide myself because I have all these images hiding them. Try to get it out. We could see the odds ratios here, that they are significant in all these different cardiovascular events, the major, the stroke, and the myocardial infarction, but also in the unstable angina. So there is an effect. In the next study, okay, see here. They also, no, in this study, they also looked at the cumulative exposure for anti-TNFs, and you could see as time goes on, number of months after the study started, you can see that the difference between the anti-TNF cohort and the methotrexate cohort increases. So here we can see that we really have a positive effect of anti-TNF treatment. Here. And in this study, they compared also, in the second study, they compared different groups, the anti-TNF group against oral phototherapy group and topical therapy group. So I guess the topical therapy, there were a lot of patients there. We don't know about their psoriasis severity, but of course they must have been much milder than the ones that got anti-TNF. So, and they were the reference group, and the anti-TNF group sort of beat both of these groups. And the final study that I'm going to talk just a little bit about, because Joel already mentioned that, the study comes from him and from Nihal Mehta, using these high-risk coronary plaque as a surrogate marker for cardiovascular events. And it's a small study, but it's actually, these patients were followed for 1 year, and they were all naive for systemic therapy when the study started. And in the final analysis, there were 89 patients that received biologics. And here we also see some patients on anti-IL-17, anti-IL-12/23, and anti-TNF. And a smaller group received only topical in UV. And these patients had extensive clinical examinations, of course. It was a collaboration between cardiology and dermatology, and also extensive imaging data with many, many arteries investigated. And the high-risk plaque is the non-calcified atherosclerotic plaque, as we have learned, is really a marker for cardiovascular risk. And here we can see the changes in the biologic group and the non-biologic group, and the number of arteries that were imaged. And we can see that it's both the total plaque burden is decreased in the biological treated patients, and especially the non-calcified plaque burden is decreased, whereas the dense calcified plaque burden is unchanged, actually. So this is really hard evidence that high-risk plaque are decreased through treatment with biologics. So this is, of course, very resource-intensive investigations to perform, but gives a very important evidence. And if you can do it in more patients, that would be very interesting. So what should we think about when we design these randomized, real-world evidence studies? I mean, ideally, the study should include the mechanisms for the association to cardiovascular disease. So is it the skin inflammation? Should we follow the skin inflammation with PASI, or do we need biosamples to follow all the inflammatory markers in circulation? And I mean, it would not be feasible to take out the endothelial cells from the brachial arteries in too many patients, you know. But also we have to, it's this combination effect, we have to take into account all the known risk factors for cardiovascular disease. So I guess we need to have all the data on these patients if we're going to come to some conclusions. So there are many challenges, but I guess we need large cohorts. And there is the challenge of harmonizing data from different big databases to be able to generalize the results. But we would like to generalize the results because we would like to have data from different populations. Also need to investigate more in detail the different classes of drugs, but because it's evident that these targeted treatments may affect the cardiovascular risk in different ways. And also, ideally, we would like clinical evaluation of the patients and mimic randomization with these propensity scores, or maybe even some other fancy statistical methods, because this is, of course, important. We can see that the data and the results can change completely if you adjust for these factors. I will just finish showing Karolinska in the summer. It doesn't look like that now. We're in the middle of winter and it's dark. This is how the new buildings compete with the old ones. Okay. So, thank you.
Thank you very much, Mona. We're running a little bit late, but we are going to do some questions. I wanted to get a chance for everyone to at least speak one more time. If you can say stop sharing your screen, Mona. Okay, great. So I wanted to ask Michael first about this idea. Does psoriasis cause heart disease, or does heart disease cause psoriasis? And does it really matter? Does it really matter, right? I see psoriasis as, something like smoking, diabetes, or something that we can change, that we can affect. So, and we have the visualization of the skin. So do you think it matters to understand which direction is happening here?
Good question. I think from an intellectual perspective, yes. From, I think, a management perspective, I don't know. I will say, anecdotally, when I see a psoriasis patient for cardiovascular risk stratification, they have some squirrely chest pain, I do a CT angiogram. I'm sometimes shocked at how little I find on the CT angiogram. Mm-hmm. So I guess I don't know if heart disease causes psoriasis. I think there is maybe it potentiates it. I mean, there's clearly an overlapping inflammatory signature. My own work and others seem to highlight the importance of the inflammasome signaling pathway, which I'm very much interested in, which is up in both psoriasis and heart disease.
And then one follow-up question on that, I guess. Do you believe in the concept that the more we can get to PASI 100, the more complete versus, let's say, residual psoriasis, the greater chance of improvement of heart disease? So that would be kind of saying MOA maybe is not important, and just if we just visualize. So do you think MOA of the drug is important, or do you think it's more important to get to PASI 100? And if you're at PASI 100, you've optimized your, your ability to affect heart disease?
Well, I think based on the studies that we're presenting, I'm not sure we fully know the answer just yet. I'm hyper obsessed with the concept of residual risk, which is after you achieve PASI whatever, do you still have risk? Our RNA sequencing data would suggest there's a degree of PASI independent transcripts that are up in psoriasis and correlate with MI and with future cardiovascular events. I will say the platelet aggregation data we showed, that's really PASI independent, like all comers. Okay. It's shocking how good the aggregation data kind of looks and is. So I think there's a lot of good reasons to get to a really good clearance of psoriasis. But the way I start these conversations in the clinic, I always focus on the traditional cardiovascular risk factors,
yes,
including a risk score, ancillary imaging when appropriate.
Great. All right, and then Joel, I want to switch to you and ask about angio-CT a little bit more. I know you focused for years on FDG PET CT and didn't see it move, quote unquote, that much with randomized trials. Do you think do you see yourself sort of repeating everything now with angio-CT, or and how would you be more clever, I guess, with RCTs now? You know, would angio-CT be the endpoint?
Yeah, so I think, you know, one of the challenges we have when we study psoriasis as a model of cardiovascular risk is that they're a good deal younger than the traditional population studied in these type of designs. So like I showed you in the clinical trials in the cardiovascular studies, they're in their 60s. Our patients are in their 40s. And a lot of these imaging modalities are really validated people in their 60s with established coronary disease. So how well they perform as a research tool, people in their middle ages is not as well understood. So that's one gap in knowledge we have. That being said, I still think it's a logical next step if we're going to do imaging analysis work. But the drawbacks are that it's going to have to be larger studies and longer than we've done with the FDG PET CT, because it takes a longer time to see a readout, and we can't give them placebo. And so then you get in a problem as well. You may do, study the IL-17s versus TNFs or something and show similar benefits. And then you won't really know, well, was it the biologics? Was it a healthy user effect? The people entered a trial, they changed their lifestyle, and those things went on. So it's not entirely clear whether that approach will get us definitive answers, but certainly give us more insight into what's happening.
Yeah, and to follow up on that, just for my edification, the radiographic burden or the difficulty of FDG PET versus angio-CT, is it easier? Is it less toxic for patients to go through that procedure? Can we be doing it more routinely with as opposed to FDG PET?
Right. So I think that the FDG PET is purely for research purposes. So there's no clinical value of it. CT angio, there's clinical value to it. There's information that could gather from that we use for patient management, which also complicates a trial design. Obviously, because someone has something on that angiogram, you have to act on it. But the type of things that Nehal is showing are more sophisticated, advanced ways of reading these type of images. CT angios are pretty easy to do, and they're more standardized in the FDG PET. We had to do a lot of work on standardized FDG PET. Even then, there's still a lot of error between centers. So I think if you had to compare it to head-to-head, CT angio has advantages scientifically, but its big disadvantage is that it takes a longer time to see change, and therefore you can't use placebo.
Okay, great. Thank you for that. And then Mona, I want to just ask about European databases. So I think my view of them is it's going to be better quality data compared to a claims database in the US. So we don't have the it seems like, biologics have been out for a long time. Like we should have more data from the Scandinavian countries, from maybe from the Great Britain database, as in terms of long-term effects. Is there is everybody working in this area working independently? Is there any move to try to move these databases together in Europe?
I think you need some very enthusiastic epidemiologists to take a hold on this, because there are opportunities, and there would be, you would think that you could tease out more data because there is a lot of things to get at. And there are no limitations. We try to get long-term data on our smaller cohort, and we can, the government will give us all the data that we need. So I think we could do better between us to collaborate more, at least in Scandinavia, where we have similar databases. Yeah.
Then a follow-up there, I guess, what do you think these days, what's the proper control? Let's say the hypothesis is that our current best biologic therapies are better than older therapies. So is there enough of the control groups in these, and I guess the ideal control would be a moderate to severe patient, not on a biologic. And it seems like that we wouldn't have as many patients like that. Is that?
Exactly. That is a problem, because most patients get something that it would affect them in these areas and would confuse the results. That's true. So I
think there's a lot. I think the challenge we have is identifying those people who has moderate severe psoriasis but doesn't get treated. But there's also a very strong healthy user effect. We've demonstrated that in other database studies before, that those who go on biologics tend to be much healthier than those who choose not to go on biologics for psoriatic disease. And that often is a form of selection bias that's just hard to overcome in these studies. And I think what we'll need to understand going forward is there the same selection bias of a TNF versus a 17 and an IL-12/23? Because there may be, since these drugs are used differently and at different frequencies and what have you, but there's some emerging data now head-to-head, at least in the room literature, that those who go on TNFs with psoriatic arthritis do better than those getting an IL-17 or an IL-12/23. There's been some criticism of that paper, but that's the next place I think we'll see data emerge, is a comparison of different biologics without a lot of understanding of the selection bias that goes into the use of these therapies.
Right. And then I think too, if we, let's say, Joel, we do see that, let's say 17s are better than 23s for improving heart disease, is that now going to go into the calculus of our, prescription writing? Will we elevate, that one drug over another based on cardiac data and not based upon our traditional skin efficacy data? Do you think you ever see that happening?
Well, I think that's the issue with psoriasis. It's a long-term disease we're trying to manage. And we've come so far with our data, but for the most part, we really understand how to treat this disease for a year or two based on our clinical trial data. If we start having larger, longer studies that give us a better estimate of the net benefits and harms of therapies, that would be distinguishing, I think. So if people had better responses to skin and better cardiovascular risk profiles over time, that would certainly be a distinguishing feature from the various therapies we have to choose from.
Right. I think it would be easy, right? If a drug class showed better skin efficacy, better safety, and better cardiac effect. But the problem would be if there's discordance, if one's better for skin, but one's better for heart, how do we balance those for our patients and make the right choice?
Yeah.
Okay. Well, I want to thank you all very much for participating today. I think within each of the three areas, we see fascinating work that's been done and a whole bunch of things that need to be done, both the basic science level, lots of different things to explore, randomized clinical trials. We're just scratching the surface. It seems like there's just lots of other work to be done. And certainly, looking at these effects of these drugs in large populations that we do have available to study. Challenges in all areas, but lots of opportunities in all areas. So I wanted to, again, thank all three of you for joining us. I hope everyone enjoyed today's webinar and will join the IPC in their future webinars this year focused on other comorbidities of psoriasis. Thank you very much.